Fantastic. Good afternoon, everyone. And if you're in Bangladesh, good evening. So welcome to today's session. We are Planetary Health Academia, and this is a session from the Faculty of Neurology and Stroke Medicine. And it's lovely to see so many of you have joined in already. So it's always good to have our participant. And the whole idea is to sort of collaborate and try and get some message across. So again, thanks for joining in. So we've got a very exciting topic today. It's autoimmune epilepsy, something that I don't know a lot about, but hoping to learn a lot today. And first of all, I will introduce you to the speaker today and also the panel members. So it gives me immense pleasure to introduce Dr. Ifat Ara Shuchita. She's an assistant professor, neurologist from USA, and she's also the program director for epilepsy. Shuchita has been always a big support for Planetary Health Academia, and she's one of our leading speakers from the faculty. So thank you, Shuchita, for agreeing to do the talk today.
Thank you.
We also have an area of specialists, experts from different areas. So we have Dr. Garrick Tan. Welcome, Garrick. So Dr. Tan is a neuroradiologist from Darren Valley Hospital in UK, and he sort of saves our skin or saves the day most of the time for us. So again, I'm really grateful to Garrick Tan for joining in today. We also have amongst the panelists Professor Rajim Nayan Chaudhary. He's a professor of neurology and he's the head of the neurophysiology for National Institute of Neurosciences. He will love to hear his thoughts about this topic. And last but not the least, we have Dr. Riaz Mahmood, a dear friend of mine. Again, he's a neurologist from Bangladesh, works in National Institute of Neurosciences. And like Shuchita, his area of interest is epilepsy. The final panelist today is Professor Tazrul Islam. He is intensivist and respiratory specialist from US, Indiana. But at the same time, he's a very busy man. He's on call today, and I'm guessing that he's stuck with some emergency, but hopefully he will join in soon. So before I give the floor to Shuchita, just a few sort of housekeeping rules. So we'll try and keep the talk for within an hour, and hopefully then we'll have about half an hour or a bit more to sort of answer some of the questions from the participants and also sort of to do a bit of brainstorming. If I could request everyone who's joined in to mute themselves so that it's uninterrupted. And also for listening intently and also participating, there's some sort of incentive. So we'll invite every one of the participants to post their questions on the chat box. And the one that sort of generates most interest will get to go home with not only some take-home messages, but a beautiful Bluetooth headset. So the panel members will decide the most interesting question at the end. So without further ado, I'll hand over to Shuchita. Thank you, Shuchita.
Thank you. Okay, so today we're going to talk about autoimmune epilepsy. This is one of the fields I'm very interested in. I mean, of course, I love epilepsy and that's what I practice. And we also eventually developed our first autoimmune epilepsy center at University of New Mexico, actually this year. And I'm so happy that we get to take care of all those patients there in the clinic and give them the care that they need. And this is a very interesting topic. And when we talk about it, you may feel this topic is not very familiar, but when we talk about the patients, you will realize how many of these patients you encounter in your life. And it's just like a syndrome that we are not very aware of and often been, not being diagnosed on right time. So let's talk about autoimmune epilepsy. So this is caused by the change in the body's immune system. Seizures are the main features of autoimmune epilepsy or encephalitis. But people can have depression. Some people present with psychosis, new onset of bipolar, and a lot of different symptoms. But seizures is going to be the main focus of the topic today. This type of epilepsy was recently included in the new way of classification in the International League Against Epilepsy, or ILAE. Most cases of autoimmune epilepsy consist of limbic encephalitis, which involve the limbic system, and that's why it involves a lot of emotion or mood psychiatric feature. It presents with inflammation and like seizure, and also patient will have some memory loss, unconsciousness, psychiatric, and some people go to the extreme when they become comatized and often admitted into ICU. When Dr. Tersbeer will join, he can give us more perspective how many times he sees those patients too in the ICU with refractory epilepsies. So in a broader spectrum, autoimmune epilepsy also include many other subtypes, and we'll talk about it eventually. So there are like febrile illness related refractory seizures, which are called FIRES. It's also part of the autoimmune epilepsy. Then you have the new onset refractory status epilepticus, or NORS, there's another name of calling it, and then cerebral autoinflammatory disease and epilepsy induced by the systemic autoimmune disorders. So let's go and talk about the prodromal symptom and when to suspect. So autoimmune disease, as I say, is all about being aware of this process or being aware of this diagnosis and thinking about it, and we put those pieces of puzzle together. Not only just like when I see the patients in my clinic, they tell me about their seizures history, and I say, tell me more about it. When did it start? Why is it so refractory? Why suddenly, all in a sudden, a 30-year-old female or male who has no past medical history suddenly started having seizures to the point where nobody can stop, and they are on like 4 or 5 medications in ICU, intubated, and it's still not stopping. Why? So that's where you question, this is something different. And the treatment and the management is also very different. So the prodromal symptom, usually patients say, it may be triggered by a fever, headache, dizziness, insomnia, or simple upper respiratory tract infection. And after the short term of fever, generally they manifest as the immunization against the self-antigen and their antibody production. It is start attacking different part of the brain, and many times it's limbic system, but not necessarily that's the only part of the brain. And most of the time, it's suspected when patient have the infection or fever at least persisted little like around 3 days or more. And so they're like different. So they will give you the history, but not necessarily all the time. When they give you the history of having fevers, which preceded to this illness, then you call it fire. But when they don't know any history of fever or any prodromal sickness, then you keep this open and you think about if there is an underlying malignancy which is causing all those autoimmune antibody production. So, and those are called paraneoplastic encephalitis or paraneoplastic syndrome or paraneoplastic epilepsy. So your 3 main thing is when you see autoimmune epilepsy, you want to find out if there is a hidden cancer anywhere, if there is an infection that triggered or is unknown. So those are the 3 main features. Autoimmune epilepsy accompanied by altered mental status, as I mentioned, sometimes they will be comatose, and psychiatric symptom or memory deficit. And there are many different type of autoimmune diseases. It all depends on which receptors or which part of the brain is being affected. If the NMDA receptor is attacked, NMDA is one of the neurotransmitters that we have in the brain. If that being attacked, then it's called NMDA encephalitis. And those are mainly characterized by psychosis, dyskinesia, movement disorder, hypoventilation, or different type of autonomic dysfunction. So sometimes you will say they have fluctuation of heart rate, bradycardia, tachycardia. They may have breathing instability, blood pressure instabilities. Then you have the faciobrachial dystonic seizures, or it's another variant which is associated with the LGI antibodies or leucine-rich gliadin inactivated protein antibody encephalitis. Oftentimes, those patients will have hyponatremia. They will have refractory seizures, and you see also facial and brachial. facial, and the shoulder dystonia. And not necessarily those are seizures. Some those may be part of the seizure, but when you do the concurrent EEG, you will see many of them are just dystonic. Beside that, you can have GABA encephalitis when the antibodies are produced against the GABA antibody. It can be GABA A or GABA B. And those are the patients who will come with refractory status epilepticus seizures, but they can also have like partial continua, focal partial continua, or focal status. And, you have to have a high suspicion and look for those antibodies. Then also patient may have antibody against the glutamic acid decarboxylase or GAD encephalitis. Many of them will present as a stiffness because that's something, is an excitatory. So when you have too much of antibody production, they will be very stiff, and a lot of the time present as stiffness syndrome or memory decline seizures and many different features or cerebralitis. Okay, so let's talk about the clinical course, like why we think about autoimmune epilepsy in some people, not everybody, instead of thinking about, oh, it's just epilepsy. So the clinical course of autoimmune epilepsy is acute or subacute in progression. So acute means somebody who is healthy, no medical issues, all of a sudden they come with refractory seizure and you cannot explain it. Refractory meaning you are trying with different medications and you're not able to stop to the point you have to send them to ICU, intubate, sedation, all those. That's one. And another one also is subacute. So subacute is basically, when patient comes to me in the clinic, I hear from them, they were healthy, like around 20 or something, or 23, and they started having seizure, and it's so refractory, daily couple of times seizures, drop attack. There is no brain lesion, no brain tumor, and there's no way to explain that. And then they also started suffering from depression, cognitive problem. And then I started questioning about if this is autoimmune epilepsy. And we talk about that. And then, this is the two type of course you can see, acute, another one is subacute progression. The subacute also come in a very bad situation. They will be on multiple seizure meds and very refractory almost daily to weekly. And before we proceed for epilepsy surgery in our center, we want to make sure that we are not dealing with an autoimmune epilepsy, because if it's an autoimmune epilepsy, this is going to be reversible. They don't need surgeries. So you have to try to suppress their immunity, whatever the trigger is. Is it a tumor which has trigger? You have to think about that. If that was a fever, fever is not there, but after fever, patient had this autoimmune, so you target with some sort of immunotherapy or chemotherapy to suppress their immunity, and you will see the seizure improvement. So oftentimes I tell the patient, it's not the seizure that I want to aim for. I want to know the cause of your seizure, and I want to help that. If the cause of the seizure is tumor, brain tumor, we would like to target that. If the cause of the tumor or your seizure is tumor or cancer somewhere else and antibody production, we need to suppress your immune system. And it's basically targeting the cause, not just blindly treating the seizures. There are some criteria in the clinic setting that we can use, and we'll talk about it. And so the viral infection, as I mentioned, I do have a couple of patients. I'm just going to give some examples. So there was a very young patient, like she was barely 19, proceeding to 20. She used to work as a teacher for, and babysit random kids. So she got some cold infection from the babies. So, and then in few days, 3-4 days, she went back to her work. Symptoms are not there, but she started acting different. Doesn't make sense. Dad was trying to talk over phone and she was not making sense. And her colleague, also thinks she's different from how she was. There's a personality change, and there is a ongoing possible focal seizure. But then the patient ended up having seizure. They transfer the patient, and long story short, that patient has autoimmune disease, and she suffered and started being in the ICU for close to 6 months. And at some point after few weeks, she got diagnosis of autoimmune disease. She got different therapies. So fever can trigger autoimmune epilepsy, simple cold, and it's called fire at that time. It's febrile illness associated autoimmune epilepsy. And it can be, it doesn't have to be epilepsy, it can be even autoimmune encephalitis, just like being confused and completely different. Tumor is another one. You always have to think about tumor for almost everybody, even if they have fever triggered, but you need to make sure you're not missing a cancer tumor. It's very common. Same girl, same story, like instead of fever trigger, we remember there was a case 3-4 years ago. There is no trigger of her all psychiatric changes and the seizures, and we scan her whole body and we find out she has an ovarian teratoma, which was causing all those autoantibody production. Once we did remove that ovary, she was completely back to normal, and she doesn't remember anything what happened. So tumor is very common, and you need to make sure you're not missing the tumor. So ovarian teratoma, thymoma, small cell cancer, neuroendocrine tumor are especially prone to include paraneoplastic syndrome. Approximately 40% of the NMDAR encephalitis, one of the variant of that, is associated with ovarian teratoma. And when we do the CT scan of the pelvis, actually we miss that. So oftentimes I make sure that they comment about ovary in the pelvic CT. If not, I like to do PET scan to make sure that we're not missing anything, or ultrasound of the ovary or female genital region. Then there are other antibodies like the contacting associated protein like encephalitis, CAP antibody. Those are associated with thymoma. So when you do chest, sometimes they miss the thymoma. So you need to make sure, even if you do CT, are they scanning all the organs they're missing? So if you want to consider PET scan. Small cell lung cancer detected in about 70% patients of the GABA-B encephalitis. And those are very hard to detect on the CT scan. Sometimes small cell lung cancer has very small lesion, and you may want to consider PET scan. Lung cancer and thymoma are found in approximately 70% of the patient with AMPA encephalitis. And then on the other hand, no tumor has been associated with GAD, but it's not exclusive. There are more and more case reports with GAD is also associated with some of the tumors. So then let's talk about a little bit more about the new onset refractory status epilepticus. So the patients with autoimmune epilepsy, they can present as a NORS. NORS mean is a very bad presentation, where I was telling you that they have to be in ICU for a long time, like months sometimes, to stop seizures. So NORS can be most severe form of the autoimmune epilepsy, and it's definitely, as a clinical presentation, is very aggressive. NORS etiology is about half of the patient, like 40% of the patient, I mean, they don't find out any cause. Sometimes 19% of the cases they find out is like 18% of the case they find out paraneoplastic, and 19% of the time they find out non-paraneoplastic, and being more common than infection. So I mean, infection is 8% of the cases, or at the time when it's infection induced, you call it fire. So it's just different name of what caused that autoimmune epilepsy. Okay, I'm gonna just quickly check question if there is anything I need to answer.
Yeah,
Consider
Shishita, so there's
psychiatric
one question in the chat box there. So basically what I get from this is that the change in the cognition and the behavior, can this be put down to entirely to psychotic symptoms, or could this be part of the epilepsy presentation itself?
It can be both. So it's limbic system. Limbic system can cause seizures, and limbic system can also have psychosis. The only way to prove it, when patient is having the psychosis, you have to put that EEG lead, and you'll see when they are having the psychotic episode, if those are focal seizures, post-ictal stage, or this is pure psychosis. But all those are presentation of autoimmune encephalitis. Does that answer the question?
I think that's great. So we'll move on, and then we'll take we'll do the answer session at the end. Thank you.
Yes, let's move on to the investigations, or how, first thing is suspicion, clinical suspicion, then you move to investigation. And you have the golden opportunity when you see the patient first time, you need to ask that question. If you don't do that, you're going to miss the whole picture and you will miss the whole diagnosis. So MRI brain, the finding of brain MRI for those patients with autoimmune encephalitis are various. They can have limbic hyperintensity, T2 weighted, or even in the flare, but they can have multifocal brain lesion. Like sometimes they have, basal ganglia lesions. Those are also common, and that's why they're associated with various movement disorder too. NORS patients exhibit progressive medial temporal atrophy even after the NORS is stopped due to the initial injury or ongoing inflammatory process. And the hippocampal atrophy that occur in NMDR encephalitis is usually, they say, is reversible, because you worry about hippocampal atrophy because as your memory center, are they gonna have those memory back or their baseline memory back? There will be some impact depending on the type of autoimmune epilepsy and the damage that occur. LGI autoantibody, this can have atrophy of various parts, including hippocampus, and then multifocal T2 weighted hyperintensity appear in the cortex, subcortical region, in temporal and frontal lobe in gamma encephalitis. Then you have other options to do imaging, like you can do a FGD PET scan for the brain or even for the full body. The PET scan revealed remarkable occipital hypometabolism in NMDA encephalitis, as well as very prominent hypermetabolism in the hippocampus and basal ganglia area. So occipital, hypometabolism is also a feature of NMDA. I remember, as I was mentioning, I do have the autoimmune epilepsy clinic where I get to opportunity to see all those patients. And there was one patient that I was covering someone, and a patient keep on coming into hospital with, they thought it's a press because it's on the occipital head region. Posterior, press is like a syndrome on the occipital lobe, which happened because of the blood perfusion change or the blood pressure when it goes up. And she has refractory seizures, occipital seizures, and every time, like when I saw her, it was almost 3 months. She was in the hospital in and out. And I spoke to, and they also considered doing a biopsy. I think they did it 1 week ago, but the result was not out there. So there was a question, is it really press? Why is it not improving? It should be reversible. And why is so much refractory epilepsy? When I saw the patient and I spoke to the husband that she was around 50. I spoke to her and I asked, was she has any history of cancer? Or, she said, no, we don't know. I said, okay, do you mind if I do a body scan and see if there is any hidden tumor or cancer somewhere? So we did a PET scan and we find out she has a parathyroid cancer. Parathyroid cancer is very hard to pick up, and and that was maybe the cause of her autoimmune attack that was happening in the posterior part. And then I, before the PET scan also, because PET scan take times, and I asked the husband, do you mind if I give her a trial of a steroid when she's here to suppress her immunity? And then we started a steroid, and it started some chemotherapy for her, and she had excellent recovery. And she eventually came to my clinic and everything. And I just saw her, I think 2 weeks ago, and she's completely normal. Like, she was on 6 different seizure medications. She couldn't talk. She was like in and out of hospital in last 3 years. Like, it's a big life, it's a big life change, So of course the parathyroid tumor has been removed. She got the immunotherapy. It suppressed her immunity, and she is coming off of the seizure medications. And 2 weeks ago, she told me, can you just completely take the last dose? I said, I will make it half, and next time I'll make it a little bit more. And we also did EEG, extended EEG 3 days for her on January. No seizures in 3 days, no subclinical seizure, nothing. So the PET scan also, the occipital lesion sometimes also add a lot of value. You have to think that occipital lesion, it's not always press. And regarding the biopsy that I was telling you later on, they did it because they were thinking about CNS vasculitis, and it shows just fibrosis and neutrophil and all of those non-specific changes. So there was no tumor or no CNS vasculitis confirmed. EEG now, in EEG, if there is anything that we should look for, honestly, the EEG shows just refractory seizures. Like, for example, I read EEGs a lot for ICU patients, a week, month, or twice a month. And when I see those patients' seizures being very refractory and I keep on reporting them, I ask them what treatment you are giving and why is it not stopping? Do you want to consider? And then I look into the chart a little bit more, and then we get the autoimmune consult, and that's how we think. So it's basically refractory seizures. It most of the time is focal seizure because it's not the full brain attack; it's part of the brain. And then for NMDA, they call it delta brush. I saw like maybe 1 or 2 cases where there was classic delta brush. So on the top of your delta wave in the EEG, you're going to see some beta or faster activity. And this is how it looks like. If you look at this EEG trace here, those are your delta waves. So each of those lines are 1 second duration. And as you know, if this 1 to 2, 4 in frequency. So frequency is basically how many waves you see in a second. So this is 2 hertz, so that's delta wave. And on the top of your delta wave, you see the faster activity. Those are called delta brush. And sometimes they are also, I mean, sometimes it looks like extreme delta brush on the very top. You have very sharply looking here. And those are the features of NMDA encephalitis seen in like 30% of the cases. Now, CSF analysis, it's a very important thing. So when they come with those type of refractory seizure, a lot of things to think, right? And you see the limbic lesion, what do you think? Herpes encephalitis, right? Is herpes? Is this some sort of meningitis which is causing all those seizures? So that's a valid question. They get CSF study done, and you will see everything has started coming back normal. But patient, you cannot stop the seizures. Then oftentimes you have to consider redoing the CSF to send the autoimmune antibody from the CSF. So I don't think we have this option to do autoimmune lab in Bangladesh, but it's more about clinical suspicion. Also, honestly, those autoimmune lab takes like 6 to 8 weeks, like almost 2 months to come back, and we start treatment even before that. So, and the autoimmune lab is also, let me give you a little bit background about it. So those paraneoplastic panel like NMDA, AMPA, GAT, those need a special lab. And one of the pioneer is Mayo Clinic in Rochester. And that's why I have so much interest in autoimmune epilepsy, because I was one of the fellow there, and I have the opportunity to work with the autoimmune pioneer there. And I haven't worked in their lab, but I get to learn a lot more about that. And also I learned about autoimmune epilepsy also in Texas, because there was an autoimmune specialist who used to help. So anyway, they have the lab in Rochester. So basically what happened, even in other part of the US, if we suspect, we send the lab to Mayo Clinic. So we draw the blood or CSF for autoimmune lab, and it carried by the special lab core and other lab in a special secure system and take it to the Rochester and Mayo Clinic. And what they do, basically, they try to see those matches, those serum antibody they have. And sometime, I remember when we were in Texas doing residency, after 2 years, sometimes we get called from Mayo Clinic saying, these patients' antibody came back positive after 2 years. Patient is gone. Which one? So they're investigating new antibodies every day, and they tell you, they keep all those serum that different patients have, and they keep on finding new antibodies every month. So they are the pioneer, but later on there are more and more lab created, because more people wherever is so much load for them. So there are different other labs also send out lab where we can send those autoimmune lab. So anyway, when we have the clinical suspicion, we often do re-tab, and then we send those autoimmune lab. There is CSF lab, serum lab. And as I mentioned, it's not the end, because you can't wait for 2 months. Those patients are very sick. You want to start treating even before the antibody comes. Autoantibodies studies are sensitive. And now here's the thing. The autoantibodies are positive for only 40 to 50% of the cases. So there is also something called seronegative autoimmune encephalitis or epilepsy. So that's why you have to have the clinical confidence to treat them. And there is a criteria, we'll talk about that. And sorry, this slide is a little blur. There are different type of antibodies that you can detect in the lab. LGI1 and MGR being the most common one. Those are the surface antigen antibody. And the less common ones are, AMPA receptor, there is Casper. It's not less common, but it's still, I'm not that old. I think I'm practicing here for almost 9 years in US neurology associated practice. I'm in training and then my practice. And in this 9 years, I have seen many of those like AMPA, Casper, GABA-B. So it's less common. The rare DPPX, GABA-A, there's ganglionic acetylcholine receptor. Then you have the GFAP receptor, glycine receptor. You have to be aware. And this is a very nice chart, because that talks about in LGI, beside the seizures, you also see autonomic dysfunction or dysregulation, like blood pressure, heart rate fluctuation, behavioral problem. And the classic thing of LGI is actually facial brachial dyskinesia. 2 years ago, I had a patient from Texas came here where I practice in New Mexico, pretty close to Texas. So some of the patients, they also come to our state, um, you know, and then that patient came and she had like ICU course and everything. And I questioned that if she has autoimmune. I did a video for her and she had faciobrachial dyskinesia, on the video. And those were not seizures though. So I started treating her with a steroid and autoimmune antibody chemotherapy, and she did wonderful recovery. She was having almost like 5 to 6 seizures per day. Many of them are grand mal, and she needed care at home. She was like 26. She stopped working. She is all psychotic symptoms. She stay home. She need caregiver 24 hours. And, whole thing changed with this autoimmune course, and she improved a lot. So LGI is another thing you have to make sure you don't forget about, the faciobrachial dyskinesia. Hyponatremia is something you can look for. Insomnia, patient often report, and limbic encephalitis. You will, if when you have sleep lectures here, you will see that a lot of the insomnia are autoimmune insomnia or paraneoplastic. So people get antibodies and they can't sleep for days, for months. And then NMDA receptors will also have they have actually more prominent autonomic features. And then encephalopathy, they have cognitive symptoms, psychiatric symptom, EEG, as I mentioned, delta brush, and dyskinesia. AMPA, they have prominent, because it's AMPA receptors are more prominent in your limbic system, temporal lobe. So they have very emotional liability, like fluctuates, like some days are very happy, then cry full, seizures, then psychiatric disorder, all those. Casper has a lot of brainstem disorders, and then, they can have like Morvan syndrome, peripheral nerve hyperexcitability, like they get electric shock type of feeling for Casper. Then GABA, GABA B, you can have ataxia or cellular feature limbic system, and they have the opsoclonus, myoclonus on the eyes. Those are classic for GABA. And then which tumor are associated? The LGI is associated, as I mentioned, with thymoma, endocrine tumors. NMDA classic is ovarian tumor, teratoma, and NMDA is very common for young female. Most of the cases of NMDA that I saw are very young, like less than 20. And it's a life-changing diagnosis. I remember a couple of patients, like I even later on, patient after treatment, she recovered so well. I even went down to, I said, what else you want? Do you want me, can I help you with something else? She said, can I get a coffee or Starbucks? She liked mocha. And I said, okay, I'm gonna go and bring your favorite coffee. And prior to that, like 2 weeks before her teratoma removal, her chemotherapy, steroid, oh, she cannot even talk. She was all paralyzed in ICU. So she had an extreme recovery, dramatic recovery in 2 weeks. And she liked mocha. So, all those things tells you they're coming back to their baseline. Then AMPA is associated with breast cancer, thymoma, small cell cancer. Then Casper is associated with small cell cancer, thymoma, and then GABA B is a small cell cancer. So this is funny. One thing I want to mention that we are neurologists, but when you see those patients of autoimmune epilepsy or autoimmune encephalitis, you may be the first person diagnosis the tumor or cancer, some part of the body. So if you are not aware of this syndrome, you will miss that. And, patient may not have the same outcome as they would have. Okay. Now, brain biopsy are also done in subcenter when they cannot find out what's the cause, if they want to do it. As I said, some of the cases, they're also done to rule out different other things like tumor or something else, CNS vasculitis. It's a little bit invasive, and oftentimes the biopsy report is very vague for autoimmune disease, just neutrophil macrophages. Here is the scoring. So those are for inpatient. You see those patients very sick. For outpatient, when do you suspect? We have a score called apto scoring. Apto scoring is basically, you will see the patient, when you see those patients in the clinic, they have new onset, rapidly progressive mental status change or seizure within 1 year of evaluation. Within a year, they had like a drastic change in their life. You give them 1 point. New onset of autonomic dysfunction, blood pressure, heart rate, even sweating, asystole, or ventricular tachycardia, bradycardia, or orthostatic hypotension, you give them 1 point. Neuropsychiatric symptom like agitation, aggression, psychosis, you give them, or emotional liability like keep on changing, 1 point. History of underlying malignancy within 5 years, even before onset of this neurological feature. It can be a concurrent, or it can be like 5 years before. So I had patients where they say, I mean, we couldn't find out anything on the PET scan because the tumor has been removed 1 year ago. So even though patients are in remission, still they can have those antibody production because it was in their lymphoma. Your not lymphoma, your lymphocyte has those record, and they keep on producing those antibodies. You give them 2 points. Viral prodromal illness within past 5 years, or I mean, in the absence of cancer. So the viral rate, this is funny, like 5 years, like everybody get colds, right? So 2 years. Then faciobrachial dystonic seizure, as I mentioned, it's very highly suspicious, 3 point. Facial in the absence of seizure, it can be just dyskinesia, you get 2 points. Seizure refractory to 2 or more anti-epileptic drug, 2 points. You have, if your CSF, you see high protein but low WBC, because the protein of the antibody you suspect, give it 2 point. MRI and limbic encephalitis, like you can see like those T2 lesions or some sort of lesion in the occipital limbic system. In the MRI, you give 2 points. So you score the patient in the clinic and you see. This is a very helpful scoring system, and I get to know about the scoring system during my fellowship from my mentor, Dr. Britton, where you can see in American Epilepsy Society, he talks on a video about the APT2 scoring, how they developed and how helpful it is to know those patients or, identify. And I asked him, like, I mean, you are an epileptologist, and how did you ended up getting interest in autoimmune disease or patient or scoring? Then he was mentioning there were a couple of patients he had in his clinic who never get better, no matter what drugs he tried. And he said, and then I went back to their video recording, why they're like that. They have a lot of features common in their EEG, like delta brush. They have a lot of things common in their clinic history. So that's how they ended up coming. And, he ended up developing the interest in autoimmune epilepsy, and he did a lot of contribution in a lot of journals and identifying those diagnoses, and also teaching the fellows and residents like me who got interest in this field. And it definitely bring a lot of perspective in a diagnosis. So 98% sensitive, this is scoring, but a specificity, and even without your antibody result that you send out the lab, you can diagnose with this thing. Epilepsy patient with F2 score of 4 or more, they warrant neuronal antibody testing. You can do a lumbar puncture, and if they have 7 or higher, it's like very highly sensitive, and you really don't have to wait for anything. You can go ahead and start treating them with chemotherapy or immune suppression or steroid. Okay, there's another scoring they have, which is also called RITE-2 scoring. RITE-2 scoring is basically when you have the F2 score, you start then the immune therapy and you see the response. And if you have good response and the seizure control, this is seronegative autoimmune encephalitis or epilepsy or seropositive, depending on the case. Now, how do you treat those? We talked about it a little bit. I'm going to go back to the treatment, just going to see screen through the question.
So there are quite a few there, Shushita. Yeah. So I think, so just to going through them. So one of them is, so how would you consider patients with pseudo seizures as one of those differentials for autoimmune epilepsy, or can this be easily differentiated?
Pseudo seizures?
Yeah. So I think in Bangladesh's context, the question came as because they get to see a lot of patients in their A&E, and they present with some sort of neurotic behavior and possible seizure-like activity. Yeah. But the question is that those pseudo seizures can these pose as a differential for autoimmune epilepsy, because there's a prominent psychiatric manifestation in these patients.
I see. Thank you. So, when we see those pseudo seizure, it's very important to, or when I have a patient who came from Mother Center and they say, I've been diagnosed with pseudo seizures. I said, okay, thank you for letting me know, but I want to start again, because many times pseudo seizures are overcalled. If you do not have video recording, you don't know if it is frontal lobe seizures, because frontal lobe seizure or hypermotor seizure looks a lot like pseudo seizure. They have pelvic thrusting, like right and left, up and down, and you will think like they're dancing. That's a frontal lobe seizure. So you need to have a very high clinical suspicion for pseudo seizures to make sure those are not seizures. And yeah, I mean, a patient with autoimmune epilepsy, honestly, they don't have pseudo seizures because they're very sick. They're very sick. They can have definitely frontal lobe seizures, and that may look like pseudo seizures, but they're very sick. They're like, they have prominent psychotic feature. And I have seen patients like that who are like bipolar. They're like in psychiatric like lock unit. I remember as a trainee, there was a patient who was like a boy with testicular teratoma. Testicular seminoma. He was like around 20, huge. He was in psychiatric lock unit and he has been brought back to neurology because his antibody came back positive. So he's not bipolar. He was having AMPA receptor antibody associated encephalitis. And I remember as a resident, I walked into the room with the security and I couldn't even talk to him because he's like literally standing. He doesn't even want to lay down on the bed. So he looked very psychotic. So then I walked out of the room because, of course, it's my safety too. So I walked out of the room. I called the parents and I said, this is what we found. And now we want to transfer him to neurology bed if you're okay. And we would like to start we can't give him a steroid. He's so psychotic. He's going to be more psychotic. So we'll start his immune therapy with IVIG. And if it doesn't work, we will start with Plex. Parents agreed and we started the treatment. Now, how are we going to get line for him, right? So we called psychiatric to sedate him with like they used some Benadryl and other things to sedate, and the nurse was able to give infusion. So they can look very psychotic, but most of the time they don't have like the non-epileptic spells or pseudo seizure, however you want to call it. But they can have it. I mean, I haven't seen it because they're extremely sick. They can't do all those movements, but you need to be very cautious because it may be frontal lobe seizures.
There's another question here from one of our pediatric neurologists, and the question is, how often would you see autoimmune epilepsy in the pediatric age group?
It's also very common. I mean, I don't practice pediatric, but I can tell you I did training, of course, in pediatrics, and I read pediatric EG. I mean, epilepsy board is kind of like I read both EGs for pediatrics and adults here. I do see, and then I kind of like notify them. This looks like suspicious. You have to think about autoimmune disease. It is as common as your adult one because pediatric tumor is also very common. And in pediatric rotation, not pediatric epilepsy, but my pediatric neurology training, I remember I saw a lot of cases of, ADEM, which is also part of autoimmune, autoimmune process. You get like after infection, simple sickness, they have huge brain lesions they get, and they recover very well with immune suppression. And then also, they have a lot of autoimmune disease in pediatric too. They have the Landau-Kleffner, they have all those, and those are pretty common too. So they start those therapies in pediatric here, and I read their EG to see if they're improving. So I will say it's as common as adult.
Right. I think we'll leave the rest of the questions after the treatment segment.
Sounds good. Okay, so let's move on to the treatment section. So how do we treat? The first thing is I want to emphasize again, suspicion. If you don't ask this question, you're going to miss it. And, having suspicion, then getting the history from the patient. History is the main thing. How did it start, when, and all those. And then the lab has importance, and then you calculate the app score, right score, all those, and then you, with the scoring and with your clinical suspicion, you go ahead and start the treatment. You do send the antibodies, but as I mentioned, you don't wait for the antibody to come back. So there are disease-modifying treatment by immunotherapy, and you also have to give appropriate anti-seizure medications for them. So the disease-modifying therapy is, you have to make sure you read a PET scan of the body or pan CT, or we send those autoimmune lab, but also we need to do certain thing like thyroid TPO antibody. The thyroid encephalitis is very common, and actually it's maybe one of the most common autoimmune epilepsy or patients that I see in my clinic. So TPO antibody need to be sent, and I think TPO antibody can be done in Bangladesh too. If you have it very high, beside being treated by endocrine, you also want to treat them. So you have to make sure there's no cancer and all those. And then you remove the cancer source if you find out anything. That's the first thing of treatment. So you have option of using corticosteroid IV, intravenous, or oral. If the patient is very sick in the hospital, you have to start IV, and you give very high dose, like 1,000 milligram of IV, Solimetro, and you are going to give it with, of course, some Protonix or PPI, proton pump inhibitor, and you have to also give it, as this can lower your calcium, vitamin D. But for short course, for 5 to 7 days, it doesn't, but still want to administer all of those. And then you're gonna also, if somebody has a lot of psychotic feature, as I mentioned for one of the patients, it's not a wise decision to start a steroid. Then you can think about IVIG or plasma exchange. So let's talk about those mechanisms a little bit. So steroid, you know how it's going to work, right? Steroid is going to suppress the inflammatory process from the bone marrow and your thyroid or your lymphocyte, and from the old channel, it will try to suppress those antibody production. That's how it helps. And you're going to give this methylprednisone or Solimetro dose for 3 to 5 days. You want to give it every day, 1,000. And then if you want to give oral, you can change it to prednisone oral. Usually 1,000 Solimetro is equivalent to 1,200 of prednisone. And it's a lot of tablet for a patient to take, but you can give the treatment same way. But the thyroid encephalitis that I talked to you about the TPO, those usually need low dose of steroid. So it's 1 milligram per kg body weight. So if somebody is 70 kilogram, you're going to give only 70 milligram of prednisone for 3 months. They need for like 3 months, and then slowly you go down, because it can suppress your adrenal gland and you don't want adrenal crisis. So you have to, over a period of time, go very slowly. So that's the treatment for the thyroid one, long one. Then IVIG is another treatment for IVIG is expensive. It's a blood product. You basically, take the blood from somebody, from the donor, you remove different things, and you isolate the IVIG or antibody from their blood and concentrate them and give it to the patient. So, and that antibody is going to help their suppress the plasma cell. So you'll see how the IVIG will bind with your plasma cell and decrease the production of those antibodies. The IVIG dose is similar like your myasthenia gravis, 400 milligram per kg daily, or 0.4 gram per kilo daily, however you want to say, over 5 days period of time. For how long? IVIG, usually IVIG are given every other day for 5 courses, 5 days. So 5 courses mean 10 days or 5 IVIG dose, but you can even give it daily. Make sure the patient doesn't have any heart issues or kidney issues, because otherwise there will be fluid overload. It's a blood product, heavy concentration. The other thing to consider is sometimes some of the patients, when I see them in clinic, they're on IVIG for like years, because their autoimmune epilepsy is not controlled, and we have to continue not the acute phase, but they continue to have weekly seizures. So every week they keep on having for months. Then plasma exchange is basically like your how you have hemodialysis. It's same plasma exchange. So they, for the kidney failure patient, so basically the blood will go and you remove all those bad antibodies in the blood, and then you send the pure or the filtered new blood, fresh blood to the people, and that's called plasma exchange. It is done usually every other day, just like your dialysis. And in between, when you have a gap, if you want to give the patient a steroid, you can, but you don't want to combo plasma exchange with IVIG, because if you are giving somebody antibody You don't want to remove that good antibody. So IVIG and plasma exchange are not combo, but of course, the steroid and plasma exchange, those are combo. Okay, now going to the chemotherapy. So you do have some chemotherapy options which it require for certain patients. You know, if those are more like a long-term therapy after IVIG, PLEX, you see, oh, patient improved. Now you have to give something for long-term, like rituximab will, have the effect for 3 to 6 months. So 1 dose or 2 doses will help you for a long time. So rituximab is one of the most common one we use for NMDA, AMPA, and many of the seronegative one. The doses are 375 milligram per meter square, not kilogram per meter square IV infusion for 4 weeks, the initial one like loading dose. And then gradually you can discharge the patient, see how they're doing, and every 3 to 6 months you can reevaluate the patient to see if they need more outpatient rituximab doses or not. And of course, it's a chemotherapy. It will have all the side effects that a chemotherapy or immune suppression, infection, all those can cause. Tocilizumab is another one. Tocilizumab is, it's a monoclonal antibody which blocks the interleukin-6 receptor, and it kind of like suppress all type of lymphocyte. It's a very good option too. Many patients who don't respond to rituximab, they can't even respond to tocilizumab. So it's a 4 milligram per kilo injection followed by increasing dose up to 8 milligram per kilo per month if you want to go like a monthly injection. So if you would think about like, do you want to give weekly IVIG or you want to give monthly tocilizumab? So, it's a little bit less doses. Neutropenia is the most common side effect, and that can cause sepsis and many other problems. And these patients are, you're giving those patients chemotherapy, and it's very long-term chemotherapy for years. So it certainly carries a lot of risk of infection. Then you have cyclophosphamide, which is another one we use. Usually the pulse infusion is given at 750 milligram per meter square monthly for 3 to 6 months, and then you can adjust the dose depending on patients. And you need to make sure you are doing all the labs or precautionary thing you do before any chemotherapy, like the blood monitoring, neutrophil count, and all of those things. Okay. There are other chemotherapies are also used, mycophenolate or morphine are actually used for your thyroid encephalitis, and or Celsed, you call it, it's most commonly used for myasthenia gravis, right? So that's oral if you want to use that one for patients. Now, for autoimmune and epilepsy patients, you have to be very careful when you select the seizure meds, because you're giving them chemotherapy, suppressing their bone marrow. If you give some drug like carbamazepine, and that's going to suppress the bone marrow more, if you give some valproic acid and that's going to suppress your platelet, they're going to have complication. So you have to be very mindful about which drugs you are choosing for those patients. So when I see autoimmune patients, let's say I'm not involved maybe from the beginning, and then the hospital call me for, if you're interested to take over, and I see, then first thing I do is I look at their seizure meds and I say, okay, can you please taper this patient down from carbamazepine or carbamazepine before I start the chemotherapy or come up with a plan, because this is going to cause more complication. We want to make it we want to improve patients' life, not make it miserable, right? So you have to choose the drugs wisely. And if somebody has a lot of psychotic feature, like, as somebody was asking about possible PNES and all those, so, bipolar patients, you can't use levetiracetam or Keppra for them because that causes a lot of psychiatric patient. You may want to use lamotrigine for them, but lamotrigine or valproic acid for them. So you have to choose according to the patient's profile and the chemotherapy that you are going to use. Now, future, autoimmune epilepsy is not even very established here in United States. Even in many countries, like people are not very familiar with this diagnosis. We may have read in our pathology book. I think first time I read about paraneoplastic in Bangladesh, actually, in pathology, Robin's book, they have those paraneoplastic panel, and I have no idea of what am I reading. And then I never saw anything in internship, never heard anybody talking about it. First time when I came here and I started doing my internship, and I said, what is this? 19-year-old girl, and she's like this, and it's an ovarian teratoma. She came like a psychiatric patient and in neurology unit. And I started questioning. I think I saw similar patient in Bangladesh, but I never thought about all those. So, this is something, somebody who has new psychotic history, it's good to think. And um, we used to have a lot of our, sorry, excuse me, psychiatric rotators used to come in our rotation, and they used to see those diagnoses and they carry that with them. And every time they learn those in their neurology rotation in first 3 months, and then they go back to their field in psychiatry and then send a lot of referral that, do you think this patient's out of autoimmune epilepsy? So this is a very interesting field, and it has a very good future because it's even, a lot of the things are unknown here in US. A lot of the center doesn't have any care for it. Um, as I was mentioning, even in New Mexico, it's a huge state. It's like, I think it's third or fourth largest state in the United States. It's pretty big. A lot of people here, a lot of population, people are suffering, and we didn't have even an autoimmune specialist here or a clinic, and we finally was able to establish or open it this year. So it's a lot of unknown things, but it's a very promising field. It's a very promising knowledge to have because it changed your patient's life dramatically and significantly. I mean, I go back and see those patients. I can't even recognize their face after 2, 3 years. I see them in a very miserable phase. I have seen them years back, and now they're like completely normal, talking to me that they don't even remember. One thing before I end, I would like to say, if you all are interested, you should watch the movie Brain on Fire. This is the movie actually on autoimmune epilepsy, and it's a very good movie to watch if you want to see how they present. And this Brain on Fire movie was written by the patient. So the patient was a writer who got affected. She has no knowledge what happened. She went back to those EEG videos and she saw what happened to her, and she may write the book, and then they video the book. And she was a patient in New York, and how there was a doctor neurologist who diagnosed her, and how, I mean, magically she improved. You should see that. And she and many patients are fortunate because you can go back to your normal life if you get the proper diagnosis in right time. Okay, so I think that's all I have to say, and I can start taking questions.
Fantastic, Shushi. That's absolutely amazing talk. So what I'll do, I'll kick off with a few questions. I think we have a sort of a question from both Dr. Mateen and one of my friends. She's a neurologist here, Ishita. And essentially, it's a two-part question. So first one is, we know that there are other systemic diseases that can affect central nervous system. So things like SLE and also vasculitis, so primary CNS vasculitis. So is there any way to differentiate between these cases clinically to start off with? Do you have a high index of suspicion for one or another? So if you can answer that one first, then we'll move on to the next one.
Sure. So when I do the workup, autoimmune encephalitis is very common with patients also who has other autoimmune diseases like rheumatoid arthritis, SLE. So we do, and Sjogren, we do all those testing too. And we also have the rheumatology help to help them. But remember that SLE, Sjogren should not have that prominent neurological symptom. So they can have SLE, rheumatoid arthritis. On top of that, if the antibody is attacking the brain too much, then you work with rheumatology to find out a good plan, which will help with both SLE and your autoimmune encephalitis. Yes, they all fall together. And the other question was CNS vasculitis. CNS vasculitis is a little bit different. The treatment is also steroid, but it's usually long-term treatment. CNS vasculitis, the diagnostic is usually, you can do a CTA or intervention, and you can see if there is like those, you have those, what is it called? Do you remember, Dr.? It's like, I'm like blanking right now. So in CNS vasculitis, it's like a knot, and like it looks like knotted appearance of the vessels.
Vascular
That's how
bleeding.
Was that?
Often we see the bleeding. Sorry, I think Dr. Tan would
bleeding,
also
yeah.
be able. Yes.
Bleeding. Okay. Yeah, you can
Bleeding.
have. Oh, beating. Okay, yes, yes, beating or knotting. Thank you. That's what I wanted to say. Yeah, so it looks like those beaded appearance, and because the inflammation is attacking part of the vessels. So CNS vasculitis is more about inside the vessels, and this is outside the vessel. It is attacking your neuron and the neurotransmitters. So the pathology is different. And the treatment, in CNS vasculitis also they use chemotherapy. So of course, you want to make sure that you choose the right chemo, right dose of a steroid, and you need to know what the diagnosis is. And CNS
Right.
vasculitis, if you will see, like they also they don't present with seizure that much. The CNS vasculitis patients that I saw, they present with like very drastic altered mental status. They look very sick, they come. If you do the CT scan, you will see there is multiple infarction or bleeding, and then you cannot, you know, you cannot fit. It's a young patient. There is no diabetes, no high blood pressure. Why there is so many multifocal stroke? There is nothing on the heart. So then you do angio, and in the angio you see the beaded appearance, or if you do the CTA with a contrast, like honestly, it's most of the time you can't see. So, you will see the pathology in the vessels, not on the neuron. Okay, I think we answered the questions.
And the second part to the question was you mentioned about all these different sort of immunosuppressants in terms of treating these patients. So what we're interested to find out is that in case of relapses, or choosing a long time chemo, would you have a certain preference to go for?
So it depends on what type they have. And so um, it relapse is very common. Almost like half of the patient will have relapse. So when we give them, see them in the inpatient first, we give them a steroid, IVIG, or Plex. And then we don't have to start chemo. We just watch them. And if they have the seizure recurrence after a few days, because the Plex is just removing the antibody, but it's coming again. Remember, the antibody life is like 3 to 4 weeks. They're going to come back. If it's coming back in 3 to 4 weeks, then you think about a chemotherapy, and you can start with rituximab, it's an NNGA, or if you have, you can start with Celset or mycophenolate morphiate if it's a thyroid encephalitis, and then you can make the plan according to the severity. If patient having like so many seizures, then you can do every 2 months. Like rituximab, you can give every 2 months. And then if you want, no, it's not that bad, you can repeat it every 3 months or every 6 months or every year. It just depends on patient's course and the recurrence rate. So you fix according to that rate.
In Bangladesh's context, where we know that we're not that a resource heavy country, can you think of any medications that would probably suit the socioeconomic status of Bangladesh?
I guess Celset is something. They mycophenolate, they use it for myasthenia gravis, right?
Mhm.
A lot, and it's an oral tablet. Um, I honestly haven't practiced that long in Bangladesh, but I guess one of the attending can say more. There is rituximab in Bangladesh too, cyclophosphamide, all of those are there too. Um, because I know my mom used to get rituximab every 2 months it's not for autoimmune encephalitis, but for cancer maintenance therapy. So they do have those because, cancer treatment is good in Bangladesh. I mean, maybe the other neurologists can tell me more about it.
We'll probably have a chat with Dr. Rajib and Riaz. So the next question, I think I'll bring in Garrick into this. So Garrick, so one of the participants asked that we know that in post-ictal stage, we at times do see some changes in MR. And is there any way to differentiate between those post-ictal changes and changes from autoimmune encephalitis?
Yeah. Post-ictal changes is usually because of the swelling that happen after seizure. So let's say somebody have,
Sorry, Shochita,
limb.
sorry to
Can you
cut you
hear
off.
me?
This question was for Dr. Tan. So if you wouldn't mind,
Oh, okay, okay. Sure, sure, sure. Sorry.
no worries.
Yeah, I think radiologically it can be difficult to be sure. A lot of our cases they present with high signal in the high flare signal, high T2 signal in the mesial temporal lobes, and of course you could argue that some of this is post-ictal. You know, generally the post-ictal changes also are reversible, but so is the autoimmune encephalitic kind of picture. So it can be difficult, but if it presents with that typical location in the limbic system, then generally I will call that as a limbic encephalitis. But I will also include herpes encephalitis in the differential, and I will say something like, you know, please exclude herpes encephalitis, and then and the clinicians can easily do that.
Can I have a follow-up question on that? So, in terms of herpes encephalitis, would you see ADC changes or hemorrhagic changes in the temporal lobes, or is it something that will help you in differentiate between the other pathologies?
Yeah. So I think with the limbic encephalitides, you tend, of course, they can be quite florid, but a lot of times they can be very subtle. Whereas I would say I see much less commonly herpes encephalitis being subtle. So when I say subtle, I mean it's like you just see a little bit of high signal change in the hippocampal formations or the mesial temporal lobe, and you might just see it on one on one side. With the herpes, you can get like hemorrhage, which again I see less. I hardly see it in the limbic encephalitides. And yes, the restricted diffusion, you see that quite a lot in herpes.
Fantastic, thank you. I think I'll move on to a couple of our Bangladeshi panelists to get some of their views. So, question to Riaz first. I think from Shuchita's talk, what we have found out that we need to be really careful in ruling out CNS infections before we go in, because as you know that the neuroantibodies can take months to come back, and we probably don't have the luxury to wait for that long before we start these patients on treatment. So in your experience, how sort of how difficult it is to sort of actually rule that out in Bangladesh's context, and then what's your experience with autoimmune encephalitis and epilepsy as a whole?
Thank you, Dr. Sujan. Actually, our experiences with the pure and autoimmune encephalitis is very limited. And we mostly experience the autoimmune encephalitis due to the other autoimmune diseases like sarcoidosis and like that. And another common autoimmune encephalitis phenomenon occurs in our country due to actually the paraneoplastic diseases which sometimes encountered. And mostly actually if a patient presented in our setting with changes in the hippocampal or the medial temporal area, we first consider the herpes simplex encephalitis, and we like to treat the patient with herpes. And if the patient doesn't respond, then we actually think other diagnosis. And as you know that the autoimmune panel actually is not available in our country, so we face sometimes difficulty to diagnose such condition. And the second part of the question, that how do we manage the infections if we get such conditions? Actually, we have our country. You know that it is a tuberculosis pandemic, endemic area. So we have to actually exclude TB before giving the immunosuppressant or the disease-modifying drugs, especially the cyclophosphamide or the rituximab. And actually, in our country, we have now the 24 TB gold test, And with the quantitative goal test, we can easily actually exclude the dormant TB. And if it is positive, actually we didn't go for the such monoclonal antibodies treatment. Thank you.
Thanks so much, Riaz. So next I would like to bring in Professor Rajib Nanchodhuri. So Rajib, what's your experience with autoimmune epilepsy in Bangladesh? And from your electrophysiology perspective, Suchita has mentioned some few things about the extreme delta brush and a few other findings. So is there any sort of tips that you can give to the audience in terms of autoimmune epilepsy?
Thank you very much. Good evening, everyone. I'd like to thank first Dr. Suchita for a nice deliberation. Actually, this is the third time I am here as a panel. Yes, we have some expertise regarding the dealing with autoimmune epilepsy. Can you hear?
Yes,
Yes.
we can.
Hello?
Yes, we can hear
okay.
you.
Can you? No. Okay, so we have some experiences in dealing with some autoimmune epilepsy patients. As you know, as some of our students are here, I'd like to tell something. There's an immune disorder in which seizures are the core symptom. Seizures are the core symptom. There are other symptoms like cognitive impairment, psychotic behaviors, abnormal movements. So in this regard, we had when we face some patients with clinical suspicion. In that case, we do the MRI. In some cases, this shows the signal changes. CSF shows pleocytosis, and then we go for EEGs. And in the last few years, we have encountered 3 or 4 cases of delta brushes and 2 cases of LG1. So a strong degree of clinical suspicion, and in some cases where all the criteria of clinical diagnosis of autoimmune encephalitis is done, we can do the antibodies. This is done in some of the labs. It is done in collaboration of some of the labs outside. So it is not a difficult task, but strong degree of suspicion is required. Some of the facilities are available, but we can avail some of the facilities from outside as well.
Excellent. Thank you so much. Suchita, I have one question for you before I move on to the next one from the chat box. You mentioned about in the acute phase using immunoglobulins and plasmapheresis. In your clinical practice, have you sort of noticed any difference in their efficacy? So one better than the other?
I think there is no literature to support that, but sometime I saw that flex or the plasmapheresis is a little bit more strong because they remove the antibody, and so you kind of like get an immediate effect. So it really depends, but sometimes I start with IVIG or steroids first, and if I don't see much improvement, then I like to do plasmapheresis, and most of the time it's very quick response. For IVIG, you have to sometimes give, because you are giving those antibody and you have to give the patient like almost 3 to 4 weeks to show the effect. But in plasmapheresis, you see immediate effect. So I don't know if it's true or, we're not comparing apple to apple. We're comparing to different drugs which have different mechanism.
Right. And one other thing, so as you've rightly mentioned that the auto antibody panel takes a long time, and at times the CSF is not really helpful, but you have to rule out CNS infection. So are you happy just to look at the cell counts and the protein levels, or do you actually wait for the viral PCR to come back?
If it's not a traumatic tab, if it's a clean tab and you have only elevation of protein and the white cell is less than 5, so it's going to be very unlikely that it's an infection. So in that case, you can go more confidently. But the other cases, like autoimmune encephalitis, when they come, it takes some weeks to actually diagnose, because initially the first thing is they rule out infection, including every infection you can think of, like all the rare infection, rare bacteria, virus, everything. And the tuberculosis someone was mentioning, we do that too. All of those will come negative. And most of the labs will be back within 2 weeks, all those viral or bacterial panel. And after that, patient oftentimes they may end up getting some antibiotic, IV infusions, or antiviral therapy for first few days when the labs are not back. But autoimmune encephalitis, you question it once you see no improvement, because if it's in bacterial meningitis or viral, you should see improvement with the administration of the drug. You don't even need the result to come back. So the result will be within a week, it will be back, but then you start questioning it. So it takes a week or two to rule out everything, and then you start your inclusion. But that's in acute setting. But when a patient comes to your clinic with refractory seizures, like every daily seizure, you know that's not infection. They're living like this for months and years, so it's something else, and you can go more confidently directly to autoimmune at that time.
Brilliant. We have the pleasure of having Professor Anisul Haq with us, and Professor Haq has some self-comments, so I'd like to bring him in.
Thank you very much for giving me the chance. I was listening and I haven't disturbed. It was good. It is difficult, I know, very difficult, because you have to start from beginning and lots of things comes up. So Ishita, I thank you for your brief presentation. Just I want to make some comments, like as a senior, I'm just saying as a senior, one point is when to suspect, like you said, where the non-epileptic seizure disorder, is there any chance of missing this type of thing? That's why, because in my personal experience, I have seen from psychiatric ward, working in UK, in the psychiatric ward, when we were referred for some patients, we had to suspect that it might be the case. So we have to be very careful about this. Second is, I think the main thing to suspect is acute or subacute onset of some cognitive changes, altered mentation with some abnormal movements. This can be the typical FBDS, faciobrachial, like we have seen it, faciobrachial movement, or palms, or say, for example, a genuine seizure. And there could be a feature of febrile illness, maybe a week, 2 like that. And another thing is, sometimes you have to keep in mind the electrolyte, low sodium is sometimes very indicative. Low sodium, especially the limbic encephalitis. So you have to keep in mind these type of things, the history, viral infections, and then mentation, change in mentation with some abnormal movement. So second is CSF. You did not give importance to CSF, but I think this is easy tool, especially maybe in Bangladesh also. It will at least give you some indication if you have high IgG index, if you have slightly raised, at least you can exclude some infections. When the protein level is high, if you have oligoclonal band, unusually, you're not suspecting any other condition. So protein, CSF, I think is good primary, simple tool to be checked with. And MRI, etc., is another thing. And also, you tried to mention we don't forget the commonest thing. All the viral antibodies, HSV1, 2, varicella, enterovirus, cytomegalo, mumps, everything we have to look for it, the screening as a whole. And also, I think the bacterial like Listeria, Borrelia, Lyme, we don't forget about this. We have to do that. And then also some other condition. I'm not going for that, because if we start from the development of onconeural, this concept of this viral thing. Another thing you have mentioned rightly to suspect is NORS and fires, definitely. these two conditions should raise the topic. I think everybody should think about autoimmune encephalitis if this is a NORS or FIRES like case with some mentation problem and abnormal movement. So that's one side. And what I was going to say, that the origin of this is the development with the onconeuronal antibodies, which I think I remember it happened in front of me, I would say. We were around 2008, 10, they started coming up quickly. Every month, every time you go to a seminar, you will hear some new antineural antibodies. There are two types of onconeural antibodies. I think just for a brief lecture to you for easy understanding, that one type is intracellular, and another is surface antineuronal surface antigen. The intraneuronal is difficult. We can't treat. Like, for example, anti-MA, anti-O, anti-Jo, like that. These are intraneuronal, and with, even PCD, we develop PCD, limbic encephalitis. Sometimes we cannot treat them, and they develop with the cancer duration. But the neuronal surface antigens are very tricky. A patient can develop symptom like, say, for example, NMDR, with which usually test with the ovarian teratoma or gynecological problem or small cell carcinoma. The antibody can develop long before, even 5 years before the actual cancer starts or is detected. So this is very, very important. This neuronal.
Haq, sorry. Sorry, can I just interrupt you? I think we have, thanks, excellent points that you've brought in. I'm just a bit mindful about time, and I have a couple of questions that I'd like to sort of ask the panelists as well, and maybe you can pitch in as well. So one of the things that one of our colleagues from UK has posted is that they use Plex instead of IVIG. I think I'll leave it to Ishita to pose your question yourself. Would you like to pitch in here, Ishita?
Salam, everyone. Actually, this is just our experience. We always consider plasma exchange if we are dealing with an autoimmune encephalitis, because, as Shuchita correctly pointed out, it takes very, very long for IVIG. And almost in those sort of emergency situations when time is brain, you have no time to waste 6 weeks with IVIG at all. So that's why I just shared our experience rather any data. So that's all I wanted to say. I actually didn't want to say. That's why I posted that. That's our experience on practical ground. But of course, there's no data. Thank you.
I think it's a very valid point, because we working in a district general hospital, not in a tertiary hospital. At times we would actually struggle to do plasmapheresis in DGH. So I think in a DGH setting, our first go-to thing will be IVIG, which is sort of readily available. But I think, right, as Ishita said, if you're in a tertiary center, then we have to transfer patients to other centers to do this.
Absolutely, Shujan, because this case absolutely should not stay in any DGH, should not be managed in DGH. I personally also go to DGH and I also work in tertiary. So as soon as you have a high suspicion and you have any kind of supportive evidence, patient should be moved to tertiary center without any delay, because of the urgency of the case.
It depends on how the patient presents. Yeah, I think Dr. Rahman, I think it also depends on how the patient presents. If the patient is like very altered, needed ICU care, and you need Plex to intervene, quickly you want to send. But there are some outpatient clinic patients that I see sometime, and I don't have to admit them. I manage them as actually outpatient plex or IVIG. So I don't know, every center is different. Like there are outpatient plex available here in US for this type of patients, or even IVIG. There are also a lot of rheumatological condition they use it, so they have the infusion center and you can have it done they can be home and you're treating them. It all depends on the severity of the patient.
Can I have ask a question? I mean, I'm probably abusing my my power as the moderator, but I'd like to ask Garrick a question. So, in terms of screening for malignancies, when the only index of suspicion that we're dealing with a possible case of autoimmune encephalitis or epilepsy, what would your recommendation be? How would you approach that? You're
I think
muted,
you're
Garrick.
muted.
Sorry, I was So actually, I rely on the neurologist to make that decision.
Well, short and sweet. Yeah, we can hear you.
Yeah, and I would say that they do request it. They do request it commonly, even in the young patients.
But would you rather go for a PET CT straight away, or would you just do a contrast head-to-toe CT?
Yeah. So previously, our access to PET was more difficult. Now that we have in-house PET reporting, I guess it's something that you could do as the first line. It's just that I'm not involved with the PET imaging. So it's a valid point, because we have had cases where the CT is negative and then they go on to have a PET as well, and then you could say, then why not start with the PET?
Yeah, I think one thing I can tell you from, so here also we don't have a set protocol. A lot of the providers do CT scan first and then PET scan. So I mean, what I have learned in my clinical experience, now I go for PET first, because, if I do PET CT, I have to do separate pelvic ultrasound, transvaginal, because ovary will be missed. Then testicular seminoma will be missed. Thymoma will be missed because CT doesn't go all the way up sometime. Then they also miss like them, and then I have to do sometimes mammogram separately. So instead of doing so many radiation, I just like to do PET CT, like a PET scan. And that's why I educate here the residents and the fellows who work with me that, if you think about autoimmune epilepsy before calling me, if you want to do something, I'll just say do a PET scan, because that's way more helpful instead of me being, okay, have you done a mammogram? Have you done this? And in inpatient setting, they don't like to do mammograms. So what about if it's a breast cancer? So PET scan give me the full picture. And from my clinic, like, as I say, clinical experience over years, I learned that the best thing to do to find out or rule out any malignancy.
Yeah, I mean, the only thing is that we don't have on-site PET CT, so that's the issue.
Yeah. So if you don't have the PET scan, then you have to do, like, remember to do PAN CT for female. You have to do the transvaginal ultrasound, mammogram separately. And when you do the CT neck, you have to mention, please go up to the, thyroid gland. So, that's something you can consider doing. So there will be 4 or 5 studies to do to make sure. And when I look at the CT scan, I look at not only the summary of the report, but I go through each of the organ that the radiologist saw or not. And if I still have clinical suspicion, I go to the radiologist, as Dr. Rahman was saying. So we go down to the radiologist and ask, can you see the thymoma or the parathyroid gland, what it is? And you just talk to them and they pay special attention on that area.
Brilliant. Ishita, would you like to share your experience? What is your go-to scan in these cases? she may have left the call. Right. I think this was always one of my questions because, as you rightly mentioned, oh, you're back, Ishita. Right.
Sorry, no, actually, Suchita very nicely elaborated the step-by-step imaging, but of course, I have the liberty to be at a tertiary center, so we go for PET scan. Definitely, we do ultrasound, as she said, for female patients, but of course, PET is our to-go. It's not easy. It takes maybe 2 weeks or 3, but of course, cancer is not running away anywhere. So PET scan is something we would always consider in difficult cases, rather multiple modality of imaging.
Riaz, how easy is it to get a PET scan in Bangladesh's context?
Actually, scan is now available in several centers in Bangladesh. Some in the government settings, we have one PET CT scan in Dhaka Medical College, and in the private settings, we have in Square Hospitals, and I think Labid also have the PET CT scan facility.
So that means if needed, you can actually go for it. I think
Yeah,
overall, I would
yeah.
like to sort of wrap it up. So again, Shuchita, excellent talk and brilliant contribution from all the panelists and our guest panelist Ishita as well. Thanks to Professor Haq for pitching in with your comments. I think if I want to take one thing away from this talk is the high index of suspicion, and not to sort of so if you don't suspect, you can't diagnose. And the other thing I would say, it's not, there is no one single test to diagnose this. So I think everyone who's listening to this, you would probably understand from everyone's comments that you have to take the overall clinical picture into context and sort of try and piece this puzzle together. And again, there are small little things matter, like things like choosing your antiepileptics. Like if you're giving dual myelosuppressive agents, you can actually do more harm than good. So all these small little things makes a lot of difference. Now, we have a job before we wrap up. So that's sort of selecting the best question. What happened? I was logged out at one point, so all the questions have disappeared from my screen, but I do remember some of them. So I think I will take the liberty of highlighting a few of these questions. So one was the sort of how to differentiate between post-ictal MRI changes with autoimmune encephalitis. The other one was in terms of choosing the medication, the immunosuppressive agent in relapsing cases, and sort of which one would you prefer? And then there was another question in terms of how to differentiate between patients with pseudo seizures and still having a high suspicion of autoimmune encephalitis or epilepsy. So I think what we can do, I do have all your contacts, so I will probably send you a common email or a text and get your views on this question, and we get a consensus on what we think was the best or most intelligent question or most thought-provoking question. Once again, thank you everyone for joining in today, and it's been amazing to listen to you all and learned a lot. I probably will start arguing with my neurology colleague more now because I know a bit more. But anyway, thanks everyone, and lovely seeing you all. Thank you.
Yes, thank you. Bye-bye.
Bye.